Good afternoon, respected faculty and colleagues. I'm Dr. Shreya Naik, and today I'll be presenting the SR class on management of endophthalmitis. Starting with the definition, it's the inflammation of internal layers of the eye with intraocular colonization and multiplication of infectious agents with suppurative exudation into the vitreous cavity and or the aqueous humor. The incidences, the post-cataract surgery incidence is around 0.072% as stated by Catan et al. Way back in 1991. But the recent era phacoemulsification gives an incidence of 0.03 to 0.04% according to recent studies. Amongst the other causes of post-operative endophthalmitis, the most common procedures causing endophthalmitis are secondary IOL and PK. Other incidences to be noted are post-intravitreal injection, which has an incidence of 0.016 to 0.026, and post-trauma 2 to 17%. Coming on to the classification, the etiological classification can be based on exogenous or endogenous routes. Exogenous is further divided into post-surgical and non-surgical. Non-surgical can be divided into post-trauma or secondary causes like infectious keratitis or scleral abscesses. Endogenous is usually through an hematogenous route from a remote nidus of infection. Post-surgical can be further divided. The chronological classification can be divided into the first one is the fulminant type, which usually presents within 4 days of the surgery, and the commonly implicated organisms are gram-negative bacteria, Streptococcus pneumoniae. Basically, these are highly virulent organisms. The acute is usually presents within 4 days to 1 week, and coagulase negative staphylococcus, specifically Staphylococcus epidermidis, is the most common cause here. The chronic endophthalmitis usually presents after 4 to 6 weeks, and they can be further divided into delayed onset, which is caused by P. acnes and fungi, and delayed entry via a bleb, usually caused by Streptococci viridans or H. influenza. Now, how does a patient present to us? The most common presentation is vision drop, as seen in EVS as well as ESCRS study, giving a percentage of 94%. Pain is also a common symptom at 74% by the EVS study, but here again 26% do not have pain. So if the patient does not have pain, does not mean we can rule out ENDOPH. Other signs can be redness, excessive tearing, photophobia, blepharospasm, swollen eyelids, discharge, and floaters. Coming on to the examination. After a thorough history as to where the surgery was done, how long the surgery was done for, and a history of diabetes and other immunocompromised state, we go on to ocular examination. The first thing that we do is check the visual acuity. According to the EVS, there was the ETDRS chart was first presented to the patient at 4 meter. If the patient could not read that, it was taken to 1 meter. And even if that was not possible, we do these tests of hand movement and perception of light. Hand movement is with the light source behind the patient, we wave our hand. It is tested at 60 centimeter. And it is said to be positive if the patient responds at least 4 out of 5 times. The perception of light is checked with the strongest light intensity available, that is usually an indirect ophthalmoscope, and it is tested at 90 centimeter. One point to be noted is we should always rule out panophthalmitis by looking for ocular motility limitation or pain. Now coming to ocular examination, the first gross ocular examination is lid edema. So this is a point where we can differentiate between the close differential diagnosis of TAS, that is toxic anterior segment syndrome, and endophthalmitis. It is absent in TAS and present in endophthalmitis. The conjunctiva is usually chemosed and hyperemic. Conjunctiva in bleb-related endophthalmitis is another point that has to be seen. There are 2 terms associated with it. One is blebitis, which means there is a bleb present with suppuration in the anterior chamber only. And bleb-related endophthalmitis is termed when there is blebitis plus vitreous exudates. As you can see on the picture, there is a white bleb which is thin and cystic in nature, and the inflamed conjunctiva is red in color. So it's called as white on red appearance. Now, moving further, we can find abundant cells and flare in the anterior chamber, AC exudates, and fibrinous membrane. We should specifically look for limbal abscesses, wound dehiscence, and suture abscesses, as they have to be dealt with in order to treat the patient. Hypopyon is the cardinal sign of infectious endophthalmitis, but as seen in EVS study, more than 75% have hypopyon, but that doesn't mean if hypopyon is absent, we can again rule out endophthalmitis, as 25% patients do not have hypopyon. Then iris, usually the patterns are lost and has a boggy appearance. There's a tendency of posterior synechia formation. Pupil reaction is usually sluggish. Coming on to fundus evaluation, the EVS has adapted this grading for media clarity. So starting with grade 1, it's described when there's a view of retina which is more than 20 by 40. The second grade is second order retinal vessels are visible. Third is some vessels are visible, but they're not of second order. Fourth is no retinal vessels visible, and fifth is no red reflex. Now coming to posterior segment evaluation, as we saw, there was haze present and has to be graded and documented. Retrolental cells and vitreous exudates also have to be documented. Ryan says that retinal periphlebitis and hemorrhages are an early sign. So if a patient comes on post-op day 1 with these signs, we should be wary of further course of endophthalmitis. Now our main differential diagnosis is toxic anterior segment syndrome, and it has to be differentiated from endophthalmitis. Both present to us with decreased vision, but TAS classically presents to us within the first day, 24 hours, and endophthalmitis is usually after post-op day 1. Pain is less in TAS, it's usually severe in endophthalmitis. Lid swelling, as we saw, is absent in TAS and is present in endophthalmitis. Corneal edema is another classical limbus to limbus involvement is seen in TAS. Vitreous inflammation is always present in endophthalmitis, whereas absent in anterior segment syndrome. And the treatment is also opposite. Here, the steroids have a dramatic effect on TAS, whereas if only steroids are given in endoph, will lead to deterioration. Now coming to management of endophthalmitis, investigation, starting with ultrasound, we can see a mild to moderate amplitude spike in the vitreous with vitreous opacity suggestive of vitritis. We should also rule out any RD or CD, any dislocated lens material, or retained intraocular foreign body. If RD-CD is present, we should explain to the patient about the poor prognosis. Ultrasound is also used to monitor response of the treatment. To confirm our diagnosis, we should obtain the vitreous specimen, which can be done either through a tap or a biopsy. A vitreous tap can be done by inserting a 26 gauge needle attached to TB syringe through the pars plana. We have to slowly aspirate out. If no fluid or vitreous is obtained, we label it as a dry tap and go ahead with a vitreous biopsy. Now, vitreous biopsy is said to be the safest method to obtain vitreous specimen. It can be done either with an infusion line or without infusion line. If without infusion line, as we can see in this picture, the aspiration probe has been replaced with a TB syringe. So vitrectomy probe is attached to the TB syringe through a sclerotomy according to the phakic status of the eye, and 0.1 to 0.3 ml of vitreous from the anterior vitreous cavity is taken. Vitreous biopsy with infusion line can also be done, but there is usually dilution of sample and need for additional sclerotomy of the infusion line is there. Now the microbiological workup, which confirms our diagnosis. Gram stain and KOH mount are usually done. As soon as we obtain the vitreous specimen, we make 2 slides and do these stains. The rest of the sample has to be sent for bacterial and fungal culture as well as antibiotic sensitivity testing. Now the possibility of isolation of organism from the vitreous is more than that of aqueous, as given a percentage of 56 to 70% was given for vitreous samples. And amongst these, gram negative were only 6% and the rest were gram positive in the EVS study. Other methods are BACTEC, automated blood culture system, and PCR. Now, before starting the treatment, I'd like to discuss this major study, endophthalmitis vitrectomy study, which was published in 1995. It was a multicentric randomized controlled trial with 420 eyes. They included eyes which had undergone cataract surgery or lens implantation within 6 weeks, had hypopyon or clouding of AC suggestive of endophthalmitis or in the vitreous, clear enough cornea to visualize the posterior segment while doing vitrectomy, and visual acuity worse than 20/50 but not PL negative. Exclusion criteria included pre-existing eye disease that limited the BCVA, any other intraocular surgery apart from cataract surgery and lens implantation, and any treatment for endophthalmitis before presentation. They divided the subjects into two groups. The first one received vitrectomy immediately as the first step of treatment, plus intravitreal antibiotics, vancomycin plus amikacin. The second group received the initial treatment as vitreous tap or biopsy, plus intravitreal antibiotics. Both the groups were re-evaluated at 36 to 60 hours, and if the intravitreal antibiotic group was poorly responded, vitrectomy was carried out. In addition, all eyes were randomized to either treatment or no treatment with intravenous antibiotics, amikacin and ceftazidime. Now the results: with the systemic intravenous antibiotics, there was no difference in the final visual acuity or the media clarity. Now coming to the vitrectomy versus injection, they saw that it depended on the presenting visual acuity. If the presenting visual acuity was more than or equal to hand movement close to face, there was no difference between immediate vitrectomy and injection in terms of vision. Whereas if the patient's presenting vision was PL positive, there was a 3-fold increase in the frequency of achieving 20/40 vision, 2-fold better chances of achieving 20/100 vision, and 50% decrease in the frequency of severe visual loss. EVS was published in 1995. So right now, the limitations that are there for the EVS study are, it may not be applicable to today's surgeries as we carry out phacoemulsification through mainly clear corneal incisions. It may not be directly applied to other forms of post-operative endophthalmitis. Systemic antibiotics, amikacin and ceftazidime was used, but no recommendation was made regarding the additional antimicrobial agents. Subjects with significant opacification of the anterior chamber or PL negative eyes, both were excluded. Now coming on to the treatment. What are the objectives of our treatment? The primary objectives would be to control or eradicate infection, manage complications and vision restoration. The secondary objective would be symptomatic relief, prevention of panophthalmitis and to maintain globe integrity. A few prognostic determinants that are time duration. So time between the surgery and the onset of symptoms and the onset of symptoms to the presentation to the clinician. Both has to be noted. Presenting visual acuity, virulence and load of organism, history of trauma or foreign body, and the pharmacokinetics of drugs. Another important thing that has to be done is the counseling of the patient. We have to inform the patient about the diagnosis, the cause of endophthalmitis, and the therapeutic intervention that has been planned. Explain the visual prognosis, admit if possible, and explain about the continuous monitoring that will be done. And written informed consent should always be obtained. Now the treatment algorithm. First we make a clinical diagnosis which is reinforced by the ultrasound. In the operative, we confirm our diagnosis by a vitreous tap or a biopsy. Simultaneously either inject or do a vitrectomy. While injecting, we should also be aware of the toxicity and we should look for antibiotic sensitivity later. The post-operative algorithm, in the post-operative algorithm, we should consider adjunctive treatments like systemic antibiotics and steroids and perform an ultrasound. Antibiotics can be given in 4 ways: intravitreal, topical, subconjunctival and systemic. In topical, we usually give a combination of 2 drugs, one hourly alternatively. In presence of corneal ulcer or wound abscesses, fortified drops are recommended. Subconjunctival antibiotics can be given in bleb-associated endophthalmitis. And in systemic, EVS said there was no use, but recent studies have shown that 3rd and 4th generation fluoroquinolones can cross ocular barrier and are being considered as adjuvant therapies in some studies. Now, intravitreal antibiotics, combination of 2 drugs which have activity against gram-positive and gram-negative organisms are to be given, undertaken with all aseptic precautions. Quadrant of injection is to be chosen carefully. So, in case there is an RD, avoid that quadrant and go to the opposite. Distance from the limbus should be according to the phakic status: 3 mm if aphakic, 3.5 if pseudophakic, and 4 if phakic. 30 gauge needle on tuberculin syringes to be used for the injection, and direction of penetration should be towards mid vitreous. Now these are a list of common antibiotics that we use. Ceftazidime is at a dose of 2.25 mg per 0.1 ml, Vanco at 1 mg. Imipenem and piptaz can also be given. The antifungals that are commonly used are amphotericin B and voriconazole. Amphotericin B at a dose of 5 microgram per 0.1 ml and voriconazole at a dose of 50 microgram per 0.1 ml. Now the dose alterations that have to be done for these injections in case of vitrectomized eye, because there is increased excretion of these drugs, we increase the frequency from 48 hourly to 24 hourly. Oil-filled eyes, half dose is to be given, and in pediatric eyes, because the globe is smaller, we use 1/3 dose. Now coming to intravenous antibiotics, in EVS we saw there was no significant difference in outcome, but the antibiotics that were used were ceftazidime and amikacin. Recent studies have found that cefazolin and vancomycin do reach the therapeutic levels, and by therapeutic levels it means above the MIC, that is the minimum inhibitory concentration in the vitreous, in inflamed, aphakic and vitrectomized eye. Results of systemic antibiotics in the EVS may not apply to today's conditions. Other adjuncts that are used are cycloplegics. As we have seen, there's a tendency of posterior synechia formation, so 2% hometropine is used, and anti-glaucoma if the IOP is high. Coming to steroids, it is a potent anti-inflammatory therapy, and recent studies by LVPI have shown that they do have a effect on decreasing the inflammation. But 2017, a Cochrane review was done based whether adjunctive steroids have to be given in case of endophthalmitis, and they found equivocal results. So it's up to the discretion of the surgeon. Now, treatment algorithm that is followed in RPC is we see the presenting vision. If PL positive, we go ahead with a vitrectomy with intravitreal antibiotics, and if the vision is either hand movement or better, we go ahead with a intravitreal injection with tap and culture sensitivity. This was another protocol that has been given by Survey of Ophthalmology in 2017, where they directly go ahead with the injection and oral antibiotics, but we commonly follow this algorithm. Coming on to vitrectomy, there are two school of thoughts. The EVS school of thought which says that we have to achieve safe vitrectomy without PVD induction and minimal but adequate vitreous removal. There was a recent study by Guinea and Kuhn et al., the CEVE study, which showed complete and early vitrectomy for endophthalmitis. There were no cases of rhegmatogenous retinal detachment in these patients, and 91% of the cases achieved final acuity of 20/40 or better, as opposed to 53% in EVS. But we follow the EVS school of thought because the retina is still necrotic and inflamed, and it's very easy to cause any retinal tear and further complication. Now, what do we do in a vitrectomy? First, we manage the anterior chamber. If there are any exudative membranes present, we remove it so that there is a clear visibility of the posterior segment. Usually, a long infusion cannula is better at 6 mm, and we have to be careful to start the infusion line only after the port is visible. Do not attempt PVD in cases where hyaloid is strongly adherent. Only do safe and adequate vitrectomy. Use maximal cutting rate and minimal suction. Early vitrectomy is considered in cases of post-injection endophthalmitis, fungal endophthalmitis, in diabetic patients, and in post-traumatic cases. In post-traumatic cases, Bacillus cereus is a common organism, and it has very poor prognosis, and hence early vitrectomy is to be considered. Now, the role of silicone oil. There's a study from our center which compared core vitrectomy alone versus complete vitrectomy with silicone oil endotamponade. The conclusion drawn was that complete vitrectomy with primary silicone oil improved anatomical as well as functional results in the post-traumatic endophthalmitis. Dave et al. From our center also showed that silicone oil has antimicrobial activity. So again, it's up to the discretion of the surgeon. Now, other types of endophthalmitis. How is post-intravitreal endophthalmitis treatment different than other post-operative endophthalmitis? So in post-injection, the treatment is more aggressive as the prognosis is worse. Early surgical intervention should be preferred in post-intravitreal endophthalmitis. Chronic endophthalmitis is usually caused by slow-growing, less virulent bacteria, P. acnes. It usually occurs from 2 months to 2 years after the IOL surgery. Chronic indolent low-grade iridocyclitis is present along with granulomatous capies. 50% patients may have an hypopyon, and the classic appearance is that of a white plaque in the posterior capsule. So this is a picture of P. acnes endophthalmitis. So if such a case is suspected, we have to keep an anaerobic media at hand, which includes a BHI brain heart infusion media or a trypticase soy agar. Intravitreal antibiotic is also to be injected into the bag. Vancomycin does have an activity against this. Vitrectomy plus capsulectomy plus IOL explant should be done as the bacteria remains sequestered within the capsular bag. Coming on to fungal endophthalmitis, delayed presentation with persistent iritis, fungus over the iris surface of the IOL, and fixed hypopyon all are suggestive of fungal endophthalmitis. Whitish puffballs and vitreous strands can also be present. In the treatment, we should always go ahead with the earlier vitrectomy with injection of intravitreal antibiotics like amphotericin B and voriconazole. Bleb-related endophthalmitis, usual organisms responsible are Streptococcus and Haemophilus influenzae. The risk factors are thin cystic bleb and intraoperative use of antimetabolites. 5-fluorouracil has a higher risk than use of mitomycin C. Inferior or nasal situated bleb and leaking bleb are all risk factors for bleb related endophthalmitis. In this case also, early vitrectomy and poor prognosis have to be considered. Coming on to endogenous endophthalmitis, it is rare, usually occurring in 2 to 8% of all cases of endophthalmitis, but it is a devastating intraocular infection due to hematogenous spread of microorganisms from a remote infection. The risk factors are many. Some of them are long-term IV catheter, IV drug abuse, immunocompromised state, and any nidus of infection like liver abscess, pneumonia, septicemia, and meningitis. So in these patients, we usually send blood culture as well, and it has seen that culture positivity occurs in more than 64% cases. Most of them are Candida positive, 66% namely, and 19% are gram negative and 15% are gram positive bacteria. In a case of Candida endophthalmitis, we see a classic appearance of string of pearls appearance. So the investigations carried out in an endogenous endophthalmitis have to be via tailored approach according to the patient, and the treatment have to be it has to be a multidisciplinary approach, and the treatment should be intravenous antibiotics. Cluster endophthalmitis by definition is outbreak of 5 or more cases on the same day in a single OT setting. Usual organisms are Pseudomonas, Staphylococcus epidermidis, and Staphylococcus aureus. Contaminated irrigating fluids, unclean phaco-tubings, improper ventilation system, and poor OT hygiene are some of the risk factors. These are few RPC studies on endophthalmitis. The first one shows that Staphylococcus epidermidis, that is coagulase negative Staphylococcus, are the most common bacteria causing endophthalmitis. Pseudomonas aeruginosa was the most common in post-traumatic endophthalmitis, and amongst fungi, Aspergillus was the most common. Further studies have shown, another study shows posterior vitreous Vick syndrome. So what they had done was they had done ultrasound biomicroscopy and found a strand of vitreous herniating into the wound, acting as a potential wick for bacteria to enter the eye. Now this is how we usually prepare the antibiotics. So usually the patient gets to us a vial of intravenous drug, either vancomycin or ceftazidime, and we dilute it. The dilution is usually a 4-step process. So Orolab has developed this E-kit or endophthalmitis kit, where the dilution is only one time. The doses that are given in that vial are vancomycin, ceftazidime, and voriconazole. So we just have to dilute it once. So it's easier for us. And there are level 4 evidences that suggest that continuous 4-step dilution also decreases the potency of the drug. Hence, this E-kit had been developed. That's it for today. Thank you.
So, thank you, Shreya. Shreya, who's your preceptor?
Dr. Shaurya.
Dr. Shaurya is there?
Yes, ma'am.
Shaurya, you would want to comment?
Yes, ma'am. Actually, she's covered it almost everything, so not much to add. But yes, I can stress on this point that the endophthalmitis is such a case that probably you'll be seeing them either ways, either in the cases that you operate, or for that matter in your casualty. So you should be very careful in diagnosing them early, and in these cases we can, if we diagnose them early and give them the right treatment, we can probably prevent vision loss. So and also one thing we do not pay a lot of attention to is that we do not take the tap, or we don't take the biopsies. So I think I would stress to all the new SRs who have joined, who are doing who are doing PPVs and managing these cases, that they should put a lot of stress on the tap or the biopsy that they take, and also try to follow up and see what came in the culture sensitivity, because some of the cases which do not respond well, I think the culture sensitivity is very important in such cases. So if any one of you have any questions, then you can put them in the chat box.
Share the this thing, please. Can you unshare your presentation? Yes. Can we all have all the videos on for the students, please? Yes. You have no questions to ask. You understood everything. Attendance taken, Abhijit?
Yes, ma'am.
Okay. Is there any other? Do we have a second presentation today?
Ma'am, I don't think so. We have a second one.
Okay, we can schedule it next time, because there was next time I think we can. Nobody has to ask anything?
I think Shreya has taken a very good class.
Okay, only one presentation. Okay.
Okay, thank you, ma'am.
Abhijit, tomorrow? I think this thing is gone, or Abhijit's connection is gone, because I can't. Aishwarya?